Welcome to PCA Deep Dive. We know you are here because you want clear systems-level thinking, the kind that cuts past jargon, noise, and lazy assumptions to get to the real architecture underneath a problem. Today, we are examining one of the most persistent failures in modern healthcare, the way the system routes patients with back and neck pain. Because despite decades of guidelines, billions in spending, and layers of medical complexity, far too many patients with uncomplicated spine pain are still being sent through the wrong doorway, into care pathways that are more expensive, more fragmented, and often less effective than they should be. This episode asks a simple but important question. If the evidence consistently points toward conservative, non-pharmacologic musculoskeletal first care, then why does the system still struggle to recognize chiropractic physicians as the logical front door for spine-related disorders? To answer that, we are pulling from a broad stack of sources: clinical literature, policy guidance, regulatory examples, federal health system data, and emerging evidence on how artificial intelligence is now repeating old referral biases in new digital forms. Because this is not just a story about back pain. It is a story about triage, legitimacy, authority, and whether healthcare systems are built to send patients where the evidence says they should go. Let's get into it.
We know you're here because you have a genuine curiosity about how massive, complex systems actually work.
And more importantly, how they sometimes completely fail us.
Exactly. You want clear, systems-level thinking without all the noise, the jargon, or the superficial talking points.
Just straight to the core of it.
Today, we have a fascinating stack of sources to unpack. We're looking at this curated blend of medical journal commentaries, state health department guidelines, Veterans Health Administration studies, and even some of the latest research on artificial intelligence.
It is quite the stack. And while those sources might sound completely unrelated at first glance, they actually all converge on one massive systemic failure in modern healthcare.
Which is the way we treat back and neck pain. The mission of this deep dive is to unpack that exact failure. We're going to explore why the current, highly fragmented medical system consistently routes patients into the exact wrong doorway for spine pain. We'll look at the compelling evidence showing why chiropractic physicians are the rightful conservative front door to spine care.
We have a deeply entrenched healthcare system that fundamentally misunderstands how to triage musculoskeletal pain.
More than 25 years ago, there was this prominent orthopedic surgeon and researcher named Gordon Waddell. He took a really hard look at how the modern medical system was handling low back pain, and he famously dubbed it a 20th century medical disaster.
And you would think, a quarter of a century later, with all of our medical advancements and sophisticated imaging, we would have solved this.
You would, but the reality is much darker. Today, in the 21st century, the situation hasn't just stagnated. It has gotten worse.
Oh, absolutely worse. Spine-related disorders are now a leading cause of disability globally.
And the amount of money we are pouring into healthcare spending for these issues has just skyrocketed into the billions. Yet you, the patient, are in more pain, you're missing more work, and you're suffering longer than ever before.
Our sources introduce this incredibly vivid, highly accurate concept that I think explains the chaos perfectly. They call it the spine supermarket.
I really love that concept. It instantly paints a picture that almost everyone listening can relate to. If you've ever had severe back pain, you know exactly what this feels like.
You do. Think of the current, highly fragmented, traditional spine care system as this massive, chaotic, poorly lit supermarket. You walk through the sliding glass doors with acute, terrifying back pain. But there is no map.
There's no customer service desk pointing you in the right direction.
There's nothing. You are essentially forced to wander the aisles completely blind. So you might panic and stumble down the urgent care aisle first, where you get a quick steroid shot and a shrug.
And when that wears off, you drift over to the general practitioner aisle.
Which is very common. And if you still don't find relief there, which you often don't, you might get bumped into the pain management clinic aisle. That's where the focus shifts entirely to chemical symptom masking.
Suddenly, and without fully understanding how you even got there, you find yourself standing in the surgical consultation aisle.
And you are doing all of this without a dedicated, specialized guide. You are bouncing from doorway to doorway, provider to provider, and as a result, you frequently end up in the entirely wrong doorway.
Receiving incredibly high-cost, low-value care that doesn't actually fix the mechanical problem of your spine. But okay, before we get to the AI piece, because that is a whole fascinating story on its own, we need to understand the mechanics of the failure. Why is the spine supermarket so broken?
To do that, we have to look really closely at the primary care bottleneck.
Right. Why is routing a spine patient through a traditional medical primary care doctor failing so spectacularly?
Yeah.
Because on paper, that is what we are all taught to do. You get sick, you get hurt, you call your GP.
It is the deeply ingrained societal reflex, but it fundamentally comes down to the realities of medical education and training. And look, it is crucial to state that this isn't an indictment of primary care doctors as individuals.
No, not at all. They are trained to be brilliant generalists.
Exactly. They are managing complex chronic diseases like diabetes, hypertension, heart failure. They are dealing with systemic illnesses, catching early signs of cancer, managing this vast, dizzying array of pharmacological interactions.
But the intricate biomechanical mechanics of the human spine, the complex interplay of joints, ligaments, fascia, and neurology in a musculoskeletal context.
That is simply not the primary focus of their curriculum in medical school or their residency. And that lack of specialized musculoskeletal training has massive compounding real-world consequences for the patient sitting on the exam table in that paper gown.
It really does. And the sources highlight some truly alarming data regarding this. When patients with acute lower back pain present to a traditional medical primary care doctor, nearly half receive recommendations that actually conflict with leading clinical guidelines. Imagine taking your car to a mechanic, and 50% of the time, they recommend a fix that the manufacturer explicitly warns will destroy the transmission.
That is essentially what is happening in the medical management of back pain.
Whether you look at the American College of Physicians, the European Spine Journal, or any major clinical consensus on acute, non-specific low back pain, the guidelines are incredibly uniform.
They are. They state clearly reassure the patient, encourage them to stay active and keep moving, utilize non-pharmacologic conservative therapies like spinal manipulation, and explicitly avoid early imaging and heavy prescription drugs.
But because the general practitioner is operating within a completely different paradigm, often constrained by 7-minute appointment slots, and lacking the specialized manual therapy skills to treat the physical joint dysfunction, they cannot follow those guidelines even if they want to.
So let's walk through what happens to you, the patient, in that scenario. You go to your GP because your back is totally locked up. You are terrified because the pain is intense.
The doctor evaluates you, but because they don't have the conservative tools to fix the mechanics, the default action is almost always investigative or pharmacological.
You get pushed toward early, unnecessary imaging. They write a script for an MRI.
And this is where we see the initiation of a deeply destructive psychological and biological cascade. The guidelines explicitly state that for uncomplicated, non-specific low back pain without red flags, meaning no signs of cancer, severe infection, or profound neurological deficits, you should not be doing early imaging.
Because an MRI is incredibly, almost ruthlessly sensitive. It is going to show every single microscopic imperfection in your spine. It will show bulging discs, degenerative joint disease, disc desiccation.
But the secret that spine experts know is that those findings are often completely normal. They are just the internal signs of aging. They're like wrinkles on the inside.
That's a great way to put it. If you take 100 people off the street who have absolutely zero back pain and put them in an MRI, a huge percentage of them will have bulging discs and degeneration.
Precisely. But the patient doesn't know that. When a patient who is already in severe pain reads that radiology report filled with terrifying medical jargon, multi-level degenerative disc disease, foraminal stenosis, disc protrusion, they panic.
They internalize the belief that their spine is crumbling, that their back is fragile and broken. And this leads directly to what we call fear avoidance behavior.
They stop moving entirely. They take to their bed. They start guarding their movements, walking stiffly, avoiding lifting anything.
And biomechanically, that is the exact opposite of what the spine needs to heal. The spine needs movement to pump nutrients into the discs and keep the musculature engaged.
So by ordering the MRI just to be safe, the system has actually triggered a psychological response that physically halts the healing process and doesn't stop there.
No, because the MRI doesn't fix the pain, and the doctor doesn't perform manual therapy. The next step in the non-guideline concordant cascade is the prescription pad,
which carry their own gastrointestinal and cardiovascular risks when used long-term. You see the prescription of muscle relaxers, which are basically central nervous system depressants that just make the patient sleepy and groggy without fixing the joint mechanics.
And historically, tragically, this exact pathway was a massive driver of the opioid epidemic. Or if the GP is really concerned by that totally normal, age-related MRI, they send the patient for a premature surgical consultation.
Moving them further down the wrong aisle of the supermarket.
Yeah.
And here's the absolute kicker, the most tragic consequence of this whole primary care bottleneck. The research strongly indicates that exposure to this guideline-discordant care, the early MRI, the cascading prescriptions, the bed rest, is an independent risk factor for acute pain transitioning into chronic pain.
That is the crucial takeaway right there. It is taking what should be an acute episode of mechanical back pain, something that should resolve in a few weeks with proper conservative management, and structurally turning it into a chronic lifelong disability.
It's just devastating when you look at it from a systems perspective. We are witnessing an epidemic of iatrogenic disability. Iatrogenic meaning disability caused by the medical treatment itself. It is a profound systemic failure of triage.
So if the traditional medical front door is consistently routing patients into a low-value, high-risk maze that actively makes them worse, it naturally begs the question, what does the correct front door look like?
If we close the GP door for uncomplicated spine pain, which door needs to be wide open?
This brings us to the core solution presented in the literature, the concept of the primary spine practitioner, or the PSP model. The sources are absolutely unequivocal about this. Chiropractic physicians are the leading non-MD portal of entry profession for spine-related disorders, period.
They are the highly trained spine experts within conservative musculoskeletal care. And we really need to pause here and strongly redefine the chiropractic profession's positioning, because there is so much outdated, lingering cultural noise and stereotyping out there.
We do. We have to be incredibly clear about what a modern chiropractic physician is and what they are not. Chiropractic is not an alternative profession.
That distinction is critical. Labeling something alternative implies that it exists outside the mainstream. Or worse, that it is a last resort you try only after traditional medicine fails.
But the clinical evidence absolutely screams that for spine pain, they should be the very first stop, not the alternative.
Exactly. It is also not a secondary or supportive-only discipline where you just go to get stretched out after seeing your real doctor. And it is certainly not just generic manual therapy or massage.
Not at all. Chiropractic physicians are highly trained, primary-level professionals operating at the absolute top of their license. They have profound clinical authority. Let's detail what that clinical authority actually entails, because I think a lot of the public misunderstands the scope of practice.
Let's do it.
They possess the recognized statutory authority to evaluate complex patient presentations. When you walk into a chiropractic clinic, the physician is not just glancing at you and looking for a random joint to manipulate. They are performing a comprehensive, sophisticated assessment. They have the authority, the training, and the legal responsibility to differentially diagnose.
Differential diagnosis is the key phrase there. Let's unpack what that actually means in practice for the listener.
It means they are actively sorting through a list of potential causes for your pain and systematically ruling them out. They are differentiating musculoskeletal conditions from systemic, pathological, or visceral issues.
So if you present with severe low back pain, they are trained to ask the right questions and perform the right exams to ensure that your pain isn't actually a kidney infection.
Or an abdominal aortic aneurysm. Or early signs of a spinal tumor. They are doing the medical triage.
They're doing the detective work. And once they have confidently completed that differential diagnosis and determined that, yes, this is a mechanical musculoskeletal issue, which the vast majority of back pain is,
they have the authority to conservatively manage it.
They treat the vast majority of uncomplicated spine pain without resorting to drugs or surgery. They utilize targeted spinal manipulation to restore joint mechanics. They prescribe specific active rehabilitation exercises. And they provide the crucial patient education needed to combat that fear avoidance behavior we talked about earlier.
And all of this is based on the most current, evolving clinical evidence.
And crucially, to round out their authority as a primary practitioner, they have the professional obligation to recommend appropriate intervention and refer out when necessary. If during that initial exam or at any point during care, they spot a red flag, say signs of a severe progressive neurological deficit like foot drop or unexplained weight loss that suggests malignancy, they don't just ignore it.
They execute a high-level, coordinated referral to the appropriate specialist, whether that is a neurologist, an orthopedic surgeon, or an oncologist. They manage the case.
This raises an incredibly important concept from our source material that I want to spend some time on, because it perfectly crystallizes the societal shift that needs to happen. It is the dentist analogy.
The dentist analogy is perhaps the most powerful framing tool we have to explain the primary spine practitioner model. But before we dive into it, we need to clarify exactly what this analogy means.
Because it's easy to misunderstand.
It is. This is not a mechanical analogy. We are not comparing the density of bones to the enamel of teeth. We aren't saying the spine is exactly like a mouth.
That would be missing the point entirely.
It is a functional, statutory analogy. It is an analogy about recognized clinical authority within a defined anatomical domain. It is about how society and healthcare systems route patients based on unquestioned expertise.
Think about how you handle your oral health. If you wake up on a Tuesday morning with a throbbing, agonizing pain in your lower molar, what do?
You do not call your general medical practitioner.
You don't. You know instinctively that your GP, as brilliant as they are at managing your blood pressure, does not have the tools, the chair, or the specific training to fix your tooth.
You also do not go to the hospital emergency room unless your face is swollen with a systemic, life-threatening infection.
And you certainly don't wander around some chaotic dental supermarket trying to find a generic pain doctor to give you a pill to mask the toothache.
You instinctively, immediately, without a second thought, call your dentist, the recognized front door for oral health. Society has granted them that unquestioned authority.
And the dentist acts as the primary practitioner for that domain. They evaluate the tooth, they take the necessary localized imaging, they clean the area, they drill out the decay, they fill the cavity, and they manage the issue conservatively in their office.
They own that domain. They only refer you out to an oral surgeon when something is drastically wrong or beyond conservative care, like a severely impacted wisdom tooth wrapped around a nerve, or massive facial trauma from an accident.
The central argument presented in the primary spine practitioner literature is that chiropractic physicians deserve the exact same societal and institutional recognition as the first stop for conservative spine care.
Just as the dentist is the undisputed master of the oral cavity in the primary care setting, the chiropractic physician is the master of the conservative management of the spine.
When you wake up with a locked lower back, or you tweak your neck lifting a box, your very first instinct, the cultural reflex, should be to call your chiropractic physician.
You should do so knowing with absolute confidence that they possess the clinical authority to triage you and refer you out if and only if the condition falls outside their conservative scope.
It is such a powerful, necessary paradigm shift. It completely eliminates the chaos of the spine supermarket. You walk straight through the front door of the recognized expert.
But it's one thing to talk about this theoretical framework of the primary spine practitioner. It is another thing to see it validated in the real world.
Let's move from the theory to a concrete example of this clinical authority and case management in action. Let's look at how state-level regulatory boards actually view and mandate the profession. This takes us to the Washington State Traumatic Brain Injury, or TBI, example from our sources.
This is a case study in clinical judgment and statutory responsibility. To understand it, let's look at a scenario that chiropractic physicians deal with in their clinics, the motor vehicle crash, or MVC.
When patients are involved in a car accident, even a moderate rear-end collision, they frequently present to a chiropractic clinic a few days later with severe musculoskeletal injuries. We are talking about acute whiplash, cervical ligament sprains, facet joint dysfunction, severe thoracic pain.
But the reality of a car crash is that it involves massive transfer of kinetic energy. The body is subjected to intense G-forces, which means these patients haven't just sprained their neck. They have experienced significant systemic trauma.
They're at a high risk for potential traumatic brain injuries, including concussions from the brain impacting the inside of the skull during that whiplash motion.
And the Washington State Chiropractic Quality Assurance Commission, which is a state regulatory board, published a newsletter providing explicit guidance on this exact scenario, and it is incredibly illuminating regarding the scope of chiropractic practice.
Now, if you look at the strict legal definition of a chiropractor's scope of practice in Washington State, it focuses specifically on musculoskeletal disorders, articular dysfunction, and the vertebral subluxation complex. They are legally permitted to diagnose and treat the spine and joints.
And they are explicitly not legally permitted to directly treat or manage a traumatic brain injury.
Right. So a plain, uneducated reading of that law might make a layperson think the chiropractor just ignores the brain injury, cracks the neck, and sends them home.
But that could not be further from the truth. What is so fascinating here is how this Washington State regulatory guidance perfectly illustrates the primary spine practitioner model in its highest, most complex form.
The board makes it clear that the chiropractic physician must perform a thorough, comprehensive physical and neurological exam. It is incumbent upon them. It is their legal and ethical duty to actively identify conditions that fall outside their scope of practice.
When a patient comes in after a car crash, the chiropractor isn't just palpating the neck. They are taking a detailed history and documenting complex cognitive and neurological symptoms.
They are looking at the whole patient. They are asking about and meticulously recording things like dizziness, vertigo, uncharacteristic short-term memory loss, sudden irritability or personality changes, photophobia or light sensitivity, sleep disturbances, and altered reaction times.
Exactly. They're documenting what the regulatory guidance calls a constellation of symptoms commonly associated with traumatic brain injury.
Yeah.
And here is where the high-level clinical judgment and sophisticated case coordination come into play.
The chiropractor manages the musculoskeletal injuries. They provide the conservative care for the whiplash. They restore mobility to the cervical joints. They help the soft tissue heal.
But simultaneously, they are monitoring the patient's cognitive state. They document the potential brain injury, and then they execute a high-level, carefully coordinated referral to another medical specialist, such as a neurologist or a specialized concussion clinic, for the definitive assessment and management of the TBI.
They are managing two parallel tracks.
Yeah.
They are treating what they're authorized to treat, and they are quarterbacking the referral for what they aren't. They don't just say, hey, your neck feels better, see ya. They ensure the patient gets the holistic care they need for the trauma.
And this entirely shatters that outdated, derogatory, bone-cracker stereotype that still unfortunately lingers in some circles. What we are describing here isn't basic manual therapy. It is sophisticated, high-level, primary medical triage.
The chiropractic physician is acting exactly as a true primary practitioner should. They are taking a complex trauma patient, parsing out the specific musculoskeletal issues that they can effectively and safely treat, identifying a severe, potentially life-altering neurological issue that they cannot treat, and safely coordinating the patient's care across multiple medical disciplines.
They're protecting the patient's health, safety, and welfare above all else.
It really highlights the physician and chiropractic physician. It is about diagnostic authority just as much as it is about treatment. So we've seen how state-level regulatory boards demand this high-level triage. But let's scale things up even further.
Let's look at systemic legitimacy.
Exactly. How do the largest, most serious, most heavily scrutinized integrated healthcare systems in the country view Chiropractic Authority? This takes us to the integration into the Veterans Health Administration, the VHA.
The VHA is a phenomenal proving ground for healthcare models. Unlike the fragmented, fee-for-service civilian spine supermarket we talked about earlier, the VHA is a massive, closed, integrated system. They are responsible for the lifetime care of the veteran.
Because of that structure, their incentives are entirely different. They cannot afford to waste money on low-value care that leads to chronic disability because they are the ones paying for the disability down the line.
They rely heavily on hard, objective data to determine what actually works. And what they have found regarding chiropractic care is incredibly telling.
It is undeniable. The data shows a massive, sustained expansion of the VHA chiropractic program. Between fiscal year 2017 and fiscal year 2024, the program grew by a staggering 344%.
There are now 299 VHA facilities across the country offering on-site chiropractic care to our nation's veterans.
A 344% growth rate in a massive federal bureaucracy is almost unheard of. You do not see that kind of systemic expansion. You do not hire that many specialized physicians unless the service is providing undeniable clinical value, high patient satisfaction, and exceptional functional outcomes.
The VA recognized that their veterans were suffering from massive rates of musculoskeletal pain, often exacerbated by the physical demands of military service, and they realized that traditional medical management pills and surgery was failing them. They needed a dedicated primary spine practitioner.
And the VHA demands high-quality, measurement-based care.
The chiropractors in the VHA are operating strictly within the hospital's evidence-based metrics, proving their clinical value day in and day out as essential primary-level spine experts for our veterans.
The military recognized the spine supermarket disaster, and they aggressively adopted the primary spine practitioner model to fix it.
Which brings us to the modern smoking gun.
The AI problem.
Yes.
Now, before we get into the bias, we should note that AI as a background technology is actually doing some great things for clinical efficiency.
It is.
The VHA research mentions using natural language processing to analyze clinical notes. It helps organize vast amounts of patient data and improves documentation, freeing up the doctor to actually focus on the patient.
That is AI functioning as a helpful back-end administrative tool. But we need to pivot to consumer-facing AI.
The symptom checkers.
Right. The digital health assistants, the chatbots that millions of people are now turning to when they wake up in pain. These tools are actively and dangerously reproducing the long-standing institutional bias against chiropractic care.
It is the digital reproduction of a structural bias.
Huh.
Let's put you in the shoes of the patient again. You tweak your lower back, lifting a heavy box. Instead of wandering into the spine supermarket immediately, you pull out your phone and ask a popular consumer AI health bot, what should I do for severe lower back pain?
And what does it say?
The AI almost universally defaults to generic, heavily risk-averse advice. It will invariably tell you, you should see your doctor.
What's fascinating here is we have to understand how the AI interprets language.
Okay.
To an AI language model, the word doctor strictly means medical doctor. It means an MD or a general primary care physician. It does not mean a chiropractic physician.
But wait, if the established evidence-based clinical guidelines universally say that conservative, non-pharmacologic care should be the first step, why is the most advanced technology in the world giving the patient outdated advice?
Because of the data it was trained on. AI models don't actually think or understand medical nuance. They learn by ingesting massive amounts of historical text.
So it's looking backward.
Exactly. For medical AI, that means they are trained on decades of hospital electronic health records, traditional medical journals, and deeply physician-centric data. They are trained on the records of the very system that created the 20th century medical disaster we've been discussing.
They are essentially reading the old receipts from the spine supermarket.
That's a perfect way to put it. The AI encodes the outdated structural assumption that the only valid entry point into the healthcare system is a general medical doctor.
Even though we know that's wrong for spine pain.
Completely ignores the modern clinical guidelines that explicitly state non-pharmacologic care is the first line of defense. It completely ignores the primary spine practitioner model.
So even though we have mountains of evidence, the Washington State Department of Health protocols, the massive VHA integration, the clinical guidelines, these supposedly neutral digital systems are failing to recognize chiropractic physicians as the appropriate conservative first stop.
It is a massive technological step backward, just as the physical healthcare system is finally starting to realize that we desperately need a specialized dentist of the spine. We are rolling out digital gatekeepers that blindly route patients right back into the broken, high-cost medical triage system.
The AI is acting as a digital bouncer, pointing patients to the exact wrong door. Let's talk about why that happens, because it's not that the AI has a personal vendetta against chiropractors. It all comes down to the mechanics of training data and system design. Consumer AI models don't just invent medical knowledge out of thin air. They have to be trained.
And they are trained by scraping and ingesting massive, unimaginably large legacy data sets.
Right. And what makes up the bulk of those legacy healthcare data sets? It is decades upon decades of hospital electronic health records, heavily medico-centric academic literature, outdated historical referral patterns, and medical texts that were written during an era when the broader medical establishment was actively, sometimes legally, hostile toward the chiropractic profession.
The AI is reading the history of the spine supermarket and accepting it as the optimal truth.
And on top of that skewed training data, there is a layer of explicit design and prompt bias. The engineers who design these consumer-facing chatbots are incredibly risk-averse, as you would expect them to be. They are terrified of liability.
They do not want their AI giving medical advice that might trigger a lawsuit. So, because the model is already steeped in that medico-first training data, the engineers put up a set of rigid guardrails that essentially command the AI, when you are asked a medical question, always default to the safest, most legally traditional medical authority, regardless of what the specific functional guidelines might say.
What does this all mean for you, the listener? Why should you care how a chatbot routes back pain, or whether a chiropractor is legally considered a primary spine practitioner?
It matters because knowing the right front door to healthcare directly impacts your life.
And your livelihood. It saves you valuable time when you are hurting. It prevents unnecessary medical debt from expensive imaging you didn't need.
Yeah.
And most importantly, it protects you from that terrifying cascade of low-value invasive treatments, the opioids, the premature surgeries, that we know can turn a temporary injury into a chronic, lifelong struggle. So as we wrap up, let's pull all of these threads together and synthesize the journey we've taken today in this deep dive. We started by looking at the sheer chaos of the spine supermarket, the undeniable statistical failure of fragmented traditional spine care.
We saw how the medical primary care bottleneck, despite the best intentions of the doctors involved, frequently leads to early imaging, prescription cascades, and iatrogenic disability.
We then contrasted that systemic failure with the proven effectiveness of the primary spine practitioner model. We've clearly established that the chiropractic physician is highly capable, highly trained, and statutorily authorized to perform high-level medical triage, complex differential diagnosis, and evidence-based conservative care.
They are the dentist of the spine. They are fully equipped to serve as the undisputed initial point of contact for musculoskeletal complaints.
And we saw that proven in the real world. We saw it in how they manage complex trauma cases, like coordinating traumatic brain injury referrals after motor vehicle collisions in Washington state. We saw it validated at the highest institutional levels with the massive data-driven integration of chiropractic care into the Veterans Health Administration.
Yet despite all of this proven capability, despite the guidelines screaming for conservative care first, we are facing a legacy medical system and now a modern digital system that stubbornly refuses to clearly point patients to their door.
It is a profound disconnect between what the science says works and how the system actually routes the patient. And that brings us to our decisive conclusion for this deep dive. As we move further into the 21st century, as the burden of spine-related disability continues to weigh on our society, we have to ask ourselves a fundamental question.
Will our massive healthcare systems, our insurance payers, and most importantly, the new digital AI tools that are increasingly influencing patient decisions, continue to stubbornly reinforce an outdated, failing medical hierarchy?
Are they going to keep dumping vulnerable patients into a broken primary care bottleneck that actively makes them worse? Or will they finally wake up to the data, update their models, and recognize chiropractic's rightful evidence-backed role as the true, undisputed front door of conservative spine care?
That is the choice we face. It is a stark choice between repeating the costly, disabling mistakes of the past century, or finally embracing an efficient, value-based model of care that prioritizes the patient's long-term health, mobility, and quality of life.
Thank you for joining us. We'll catch you next time.
So as we close this deep dive, the takeaway is clear. Patients with musculoskeletal pain deserve to be routed toward the established expert in conservative spine care, not pushed deeper into a fragmented system that too often delays the right care, increases cost, and complicates recovery. Chiropractic physicians are not outside that conversation. They are central to it. They have the statutory authority to evaluate, diagnose, form care plans, manage conservative treatment, and refer when necessary. That is not a side role. That is a point of care role. If healthcare systems, policymakers, payers, and even AI tools are serious about evidence-based care, then they have to stop routing patients by outdated hierarchy and start routing them by clinical logic, statutory authority, and outcomes. If you are not a member of the Pennsylvania Chiropractic Association, please consider joining and helping with this fight. Please consider supporting the PCA PAC. If you are outside Pennsylvania, support your local chiropractic association. We need everyone in this profession engaged, because this is not just about our rights to practice. It is about making sure patients get the care they deserve from the providers best trained to deliver it. Until next time, thank you for joining us on this deep dive.